eliminate some stuff from studying to make it a little bit easier, I guess. But we'll come to it in due time. So we're going to be talking about ventilation and gas exchange disorders. So this is going to be looking at the lungs. So for the next 2 lectures, it's going to be a lot of lung stuff. So there are different vocabulary words we got to learn. Hypoxia, decrease in oxygen or decrease in tissue oxygenation. Hypoxemia is a reduction in the partial pressure of oxygen of the arterial blood. You know what partial pressures are? Or no? So gas is weird because it expands out to fill the volume of the space. So it's not about like a volume to measure it, but what you can do is you can look at what's the force of expansion of gases. And so that's what we call air pressure, right? And so we talk about a lot of that with like your tire pressures, right? Your air pressures, how hard is it pushing against that rubber to make that tube full, right? A partial pressure, and so what you can do is you can measure like how much pressure is in the atmosphere, and that's how much pressure is being put on your lungs because it's equivalent. You're just breathing in and out whatever that pressure is. What a partial pressure is that's the total volume of gas. What a partial pressure is it's how much each individual collection of collection of molecules are pushing on the environment. So you have a partial pressure of oxygen, you have a partial pressure of nitrogen, you have a partial pressure of carbon dioxide, and when you add those all up, that is the total pressure, right? So it's just breaking down the pressure pushed on the environment by each molecule that makes up that collection of gases. Does that make sense? So when you have a partial pressure of oxygen, that's how much oxygen, right, which is the important molecule you're trying to breathe in with your lungs. That's how much oxygen's in your lungs whenever you are breathing in, and then the partial pressure of carbon dioxide, which is what you want to breathe out, is it's also there. So if you reduce the amount of partial pressure of oxygen in the arterial blood, then you're reducing it's pretty much like a concentration of oxygen in the blood, effectively, is what you can kind of look at it. But because it is a gas, it's not called a concentration. Right? Hypercapnia is an increase in carbon dioxide contents of the arterial blood. We have this Dalton's law of partial pressures, where you can calculate the partial pressure based off of a percentage, but that's kind of like a physics thing. We're not going to do that here. The atmospheric level is 760 millimeters of mercury. At high altitude, the pressure is lower, so the partial pressure of oxygen is lower, right? So so you can think of it as like the Earth, gravity is highest in the center, and so the further out you go from gravity, from the center, the lower the effects of gravity are, and so that's also applicable to gases. So gases, you have less pressure of gases at higher elevations, and that's why it's harder to breathe. Like if you ever go skiing or like hiking, it's harder to breathe when you get toward the top of a mountain because the total pressure is lower, and because the total pressure is just the summation of all the partial pressures that whenever you go hiking, it's harder to breathe because the partial pressure of oxygen is lower. As far as blood gases, the 2 main ones are carbon dioxide and oxygen. The partial pressure of oxygen is 80 millimeters of mercury, while the partial pressure of carbon dioxide is 35 to 45. There are 2 forms of oxygen, when it's bound to hemoglobin and when it's not bound to hemoglobin, and it's just dissolved in the blood. So when it's bound to hemoglobin, because hemoglobin has this oxygen binding site right at where that iron molecule is, the most of your oxygen is going to be bound to hemoglobin, because that's kind of the whole purpose of hemoglobin, is for transport of oxygen. So it's 99% of it, but 1% is actually just dissolved in your blood. Carbon dioxide is also similar, right? There is carbon dioxide bound hemoglobin as well. The only thing is that most of your carbon dioxide is actually in the form of a bicarbonate ion. It's that equilibrium I think we drew on somewhere one time, but carbonic acid whenever it mixes, or carbon dioxide whenever it mixes with water, it forms this carbonic acid that then dissociates into carbonate and a hydrogen ion, and most of your carbon dioxide is in that form because that's a buffer that your body can use. But some of it's also just dissolved as carbon dioxide. So when you exhale, you remove carbon dioxide from your blood, and the carbonic acid goes down, and your blood pH goes up. So this is like a way that you can actually buffer your body. So if you have a whole bunch of hydrogen ions in your body, you can exhale more, and it gets rid of the carbonic acid, and you can lower your pH. Hopefully that makes sense, but if not, just come and ask me. So we're going to be talking about ventilation and perfusion. So ventilation is oxygen going into your lungs, while perfusion is that oxygen moving from your lungs into the blood, effectively. And so when there's a mismatch between that, right, when you don't have proper, you need for this to occur in a healthy manner, you need to have proper ventilation and perfusion. You can have problems on both sides of this. You can have something blocking your airways, or your airways, like if your airways constricting, that's another way that you block your airways. And so you can block the ventilation of your lungs, or there could be something blocking your blood vessels, and you're actually blocking the perfusion of that. You have perfectly fine amounts of oxygen in your alveoli, but it's not going into your blood. So hypoxemia is where you have less oxygen in your blood, right? Hypoxemia. And it's where you have around 60 millimeters of mercury of oxygen. And it can be caused by either hypoventilation, impaired diffusions, inadequate circulation of blood through the pulmonary capillaries, and mismatching of ventilation and perfusion. And it manifests itself with an increased respiratory effect. So, right, you don't have enough oxygen in your body, so your body's trying to compensate and breathe more to increase the amount of oxygen that goes into your body. But if there's something blocking that proper exchange, sometimes those compensatory mechanisms aren't enough. And then because you have improper gas exchange, that carbonic acid builds up in your blood, and you actually have metabolic acidosis, which we will talk about later on in the semester. I think we're going to go over those lectures. I can't imagine me cutting that. It leads to cyanosis, impaired sensory neurological functions, activation of compensatory mechanisms, right, and chronic hypoxemia, increased ventilation, pulmonary vasoconstriction, and red blood cell production, right? Your body's just trying to correct whatever the issue is, not necessarily by solving whatever that issue is. This contrasts to hypercapnia, where you have around a 50 millimeter of mercury partial pressure of carbon dioxide. So you have hypoventilation and a mismatch of ventilation and perfusion, usually accompanied by decreases in arterial partial pressure of oxygens. And this manifests itself with increased respiratory effort, respiratory acidosis again, right? Same reasoning, and vasodilation of blood vessel, where you have headaches, conjunctival hyperemia, and warm flushed skin. Depression of central nervous system function, decrease in air firing, carbon dioxide narcosis. So just make sure you know these. This lecture in particular is going to be a lot of, these two lectures actually are going to be a lot of just knowing generally what these diseases are, like what's bolded about each disease, and then just being able to identify that for test questions. So it's a lot of just, what is this disease? A, B, C, or D, you know. Have you heard about chemoreceptors? These so these are receptors that actually can detect, they measure the partial pressure of carbon dioxide and the pH in the cerebral spinal fluid. So it's a way of your body reading how well oxygenated is your body, and how much carbon dioxide do we have? Are we balancing those two levels properly? There are central chemoreceptors and peripheral chemoreceptors, and what's great about these is that once they detect that there's something off, if you have too much oxygen or too much carbon dioxide, these are what regulate your respiratory effect, right? So this happens a lot when people exercise, that you're using up the oxygenation in your body because it's going into your tissues for muscle contraction. So so your chemoreceptors detect that low or decreased amount of oxygen in your blood, and then it increases the respiratory flux, so you breathe more, and it increases that, and that's why your breath increases whenever you go running or whatever. And so it's all mediated by these chemoreceptors that detect these cerebral spinal fluid. So we're going to be talking about some disorders here: obstructive lung disease, obstructive airway disorders, restrictive lung diseases, and then pulmonary vascular disorders and ARDS, or respiratory failure. So the first one is this obstructive airway disorders, where this is in the form of bronchial asthma, chronic obstructive pulmonary disease, COPD, and I hate this word, bronchiectasis, bronchiectasis, whatever, that word, and cystic fibrosis, which I think we talked about briefly in the genetics lectures, but we'll revisit it. So with bronchial asthma, right? So this is what we're talking about when we have obstruction of the airways, right? And so what's going on with asthma is that you have this thickening of the bronchioles, bronchial asthma. And so because you have a thickening, airway can't move in and out as easily through the airways to the alveoli, and so you can't breathe as well. And so obviously it's going to impact how much oxygen's in your lungs from the ventilation side of things, right? It usually occurs because of inflammation, and you have hyperactive airways, episodic, right? Inflammation meaning like this is just it's becoming bigger because of an influx of cells and all these inflammatory mediators that are released by your immune system usually. And persistent changes may occur: mucus hypersecretion, injury to epithelial cells, smooth muscle hypertrophy. If this occurs enough, and blood vessel proliferation. And there's different classifications, but y'all don't really need to know. We're going to require y'all to know that as far as intrinsic and extrinsic causes. But yeah, there are extrinsic being like this is like your immune system causing this inflammation, and intrinsic can be either something wrong with the actual bronchioles itself. So with bronchial asthma, you have this smooth muscle is usually contracting, and so it's restricting your airway because of that, because of these smooth muscle contractions. Intervention of the autonomic nervous system. So you have parasympathetic stimulation through the vagus nerve receptors and cholinergic receptors, and you have which leads to bronchoconstriction. And sympathetic stimulation through the beta 2 adrenergic receptors, which bronchodilation. So what let me talk about it later. No. So what's important here is that because you have this brachial inflammation that's happening, what you have to do is, do y'all know like what people do for asthma, like what the quick cure is?
Corticosteroids.
Yeah, right. So it's inhalers, right? Mm-hmm. And inhalers are just epinephrine, which are corticosteroids. So it switches that parasympathetic sympathetic innervation, and it just, so instead of constricting the airways, it just relaxes it, and it's like stupid. It's like stupid fast. You ever like seen people take an inhaler? Mm-hmm. It's like okay, yeah. It's like these people can just. I had a friend do it one time in front of me, and it like shook me. Yeah, and then, like they were like struggling to breathe, and then they just breathe this inhaler, and then they're just like cured. It's crazy. I don't know. So yeah, really, it's a great invention, really. For atopic asthma, earlier acute phase response developed within 10 to 20 minutes. Release of chemical mediators of IgE. So this is your your extrinsic asthma, what's happening here is that your body produces these IgEs, which we talked about. Yeah, these are the antibodies, right? So you can recognize the classes. These are antibodies released from B cells, which are or mature plasma cells, and these IgEs will then float around, and then they're reactive to typically something. You can have it be like some antigen, whether it be a pathogen or some type of allergic response, a hypersensitivity. And these bind to these mast cells. And we talked about mast cells mediating allergic responses. The mast cells can then cause this inflammation of the bronchioles and cause this asthma. And so it's the release of these chemical mediators presenting IgE to mast cells. And the IgE bound to mast cells is what triggers these cytokine releases. And that's what causes eventually these bronchospasm, these thickening of the bronchioles. And it's associated also with increased mucus secretions. That's all cytokine mediated. It's a protective mechanism that your body just has. We won't go into that. They develop within 4 to 8 hours, but may persist up to even 24 hours. Inflammation increases airway responses, release inflammatory mediators with the recruitment of basophils, eosinophils, right? So you just start the whole immuno cascade. Once you activate the immune system, a lot of little pieces and parts from various classifications of the immune system get pulled in, and what'll happen is because all these immune mediators are pulled in, it damages these cells because the immune system intrinsically, in and of itself, tries to destroy things, right? And if there's not much to destroy, like it's an allergen, then the body will destroy these epithelial injuries, and we'll talk about that a little bit more with ARDS, because you have to remember these cells are filled with fluid, and so if that fluid gets popped and released, then it's going to be released out to where, and it's going to flow to where there's nothing present, and so that's what your alveoli is just an empty sac, and so you fill these empty sacs that are mediating gas exchange with fluid, and it's very problematic. As far as intrinsic non-ectopic asthma, there's different characteristics, right, that you look for to diagnose this stuff. It would be normal IgE levels, right, because IgE is an extrinsic, causes extrinsic asthma. So if the IgE levels are normal, then that's not extrinsic, so the other option's intrinsic. And it's not linked to any specific antigens. There's a family history of it. Onset is usually adulthood. And there's different triggers, whether it be viruses, exercise, colds, emotional stress, drugs.
I know right now we're actually on asthma in pharmacology. Well, we take our exam, and one of them is an anti-IgE.
Yeah. Yeah, I think you actually talk about it.
Dole or something.
I don't know. Maybe not. I don't know. I'm not gonna make y'all learn. But yeah, that's exactly right. But that'd be good for extrinsic asthmas, where you have you try to. I think the purpose of those drugs, and y'all probably know better than me, they like sequester away the IgE. I think. Did y'all learn about the MOA, the mechanism of action for that drug?
Antibody therapy.
IgE. I don't know. Whatever.
Yeah, it's probably in there, but they didn't make us focus. Yeah, they didn't make us really like focus on it.
Yeah, whatever. But yeah, so that makes sense, right? We'll just skip this. We went over this briefly, but yeah, if y'all went over asthma and farm.
Well, it says that the therapeutic use in moderate to severe persistent asthma, and then that's the one that you have to take like every 4 weeks, and it's really expensive.
Oh,
like $10,000 a year or something.
Jesus.
For O'Malley's
Fuck.
I know.
It's
I
like
remember you saying like for
almost 1,000 bucks a
antibodies,
month.
the ending is mob. That's how I kind of remember that. So it's
Oh,
omel.
MAB.
Yeah.
Monoclonal
Omab,
antibody.
whatever. Omelizumab.
Yeah, sure.
Xolair. And there's a high cost. The TU is moderate to severe persistent asthma. Administration subcutaneous, 4 weeks. And then the pharmacokinetics is plasma 7 to 8 days, and the adverse effects is injection site infection, cancer.
Gotcha. Fun facts.
Right, right.
There you go. Man,
Not
I'm
to
so
get
glad I'm not
cancer.
taking that test. I would fail a pharmacology test because I don't do well memorizing. I have to intuit everything, and so that's just a whole bunch of just memorization in
Yeah,
that
it's like
class.
how everybody drugs me up.
Yeah, and I get them all confused because they all sound like
Yeah.
you know, it's all I don't know. Yeah.
No, literally.
I feel you. So the next one's chronic obstructive pulmonary disease, COPD. Everyone's heard the TV commercials about COPD. This is a group of respiratory disorders characterized by chronic and recurrent obstructive of airflow in the pulmonary airways, and they include emphysema and chronic obstructive bronchitis. Enlargement. So emphysema is the enlargement of air spaces and destruction of lung tissues, and this chronic obstructive bronchitis is increase in mucus production in small airways and chronic productive cough, right? You know what that means, right? Productive cough. There's dry coughs and productive coughs.
Productive would be probably producing mucus.
Yeah, it's like when you cough something up, something actually comes up. Dry coughs is where you're just like, and then like nothing comes up, and you're just like, oh, that didn't do anything. The mechanisms of is inflammation and fibrosis of the bronchial walls. Makes sense. Uh, and hypertrophied mucus glands, which leads to excessive mucus and obstructive airflow. You just got to make sure you don't get this confused with cystic fibrosis. Is the something that other students might struggle with because both are like both start with a C and then they produce mucus and stuff like that. So make sure you get that straight in your head. So another thing. Oh, sorry. Okay. So we have emphysema and this chronic obstructive bronchitis. So the way that these kind of present themselves in different manners, right? So with emphysema, it's a loss of lung elasticity and abnormal enlargement of the airspace distal to the terminal bronchioles with destruction of the alveolar walls and capillary beds. And this is something that a lot of smokers get. But it can be inherited deficiency in alpha-1 antitrypsin. This is a really cool protein if you ever study about it in like the biochemical level. I won't nerd out too hard right now, but I've done a lot of reading about alpha-1 antitrypsin for my work. But the way that you can remember this is that these are the emphysema is the pink puffers. They have increased respiration to maintain oxygen levels, and dyspnea, increased ventilatory effect, and it's a lack of cyanosis, right? And that contrasts to chronic bronchitis. We'll talk about the blue boaters, but what this is that this is chronic inflammation of the bronchioles. Yes. It represents the airways obstruction of the major and small airways. It's marked by an increase in goblet cells and an excess mucus production with plugging of the airway lumen, inflammatory infiltration, and fibrosis of the bronchial walls. So what the big thing here is these blue. So here you have a chronic productive cough, but you have these blue bloaters where cyanosis is the big way that you can do it. Another thing with, sorry, I forgot to do this. With this emphysema, you have this barrel chest. You kind of picture here, and you can see it's because of this hyperinflation of the lungs.
So what about like people who like Tesla? The man who made Tesla. Yeah. Doesn't he have like a
It's
barrel
confusing.
chest? Elon
Um,
Musk.
maybe I don't know.
I was just
These aren't just
asking.
like a barrel chest is it to be confused with like fat deposits or like muscle.
Well, I was just wondering because it looks almost like a
Yeah,
barrel
it's
chest, you
it's
know. So I was
it's
like,
barrel because of the lung expansion, not because
okay,
of like
fatty.
the stuff around the lungs. Yeah, or the rest of the. Yeah, I imagine that can get confusing, admittedly.
A few of them got that.
Wait, what?
Nothing.
Okay. um, yeah, so make sure you get emphysema and chronic bronchitis. Sorry, chronic bronchitis can uh, distinguish between those two. Um, there's also bronchiectasis, where you have pathology, just where the pathology is the destruction of the smooth muscle and elastic supporting tissue of the bronchi and bronchioles, and this is caused by obstruction and chronic persistence of infection and inflammation. So this is like a lot of bacterial things that cause pneumonia will get in there, and then there's just it just stays. And a big thing that manifests itself is outside of like the lungs is you get these like clubbing of the fingers that it's very distinctive. Um, but then it's also associated with weight loss and um, coughing and a lot of course, respiratory problems, bronchiopulmonary, and reoccurring bronchiopulmonary infections. A lot of infections of the lungs. All right, so cystic fibrosis, last one in this category. Do y'all remember what we talked about with cystic fibrosis? So it's this mutation in this CFTR, the cystic fibrosis transmembrane regulator, which is a fancy ion pump. And so we talked about how ions do not get pumped out and they're retained within cells. And so there's not a following of liquid into the um, extracellular space. And so because of this, you get really, really thick mucus. And because it's so thick that it doesn't move very well, right? That water that comes in with these ions is important for moving that liquid. And so what happens is you have a buildup of really thick mucus that doesn't um, get cleared very well, and you can't breathe. Is effectively what's going on there. And so you get an accumulation of viscid mucus in the bronchi, and it obstructs the airways. And this is associated with, where does it say it? Oh, there it is. A lot of salt in the sweat, to where this is typically diagnosed pretty early, like as babies, because of mothers kissing their children, and they just taste really salty. Apparently, I don't know.
Salty.
Yeah.
It makes sense.
And it's also associated with a lot of chronic infections as well, because again, you're not moving that fluid. There's a lot of fluid that catches this mucus. One of the main purposes of it is to catch bacteria and viruses and stuff like that, and then like move them out of the lungs. But because this fluid is so um, viscous that that it can't remove these pathogens. Yeah, whatever. The so another um, disorders of lung inflation, conditions that obstruct the airways, causing lungs compression or produce lung flaps. So if you remember your lung physiology, you have got this pleural space here in between the lung and the rib cage, and that allows your lungs to expand a little bit. So whenever your lungs, so this is going to be important for this, right? Pleuritis. So this is an inflammation of that pleura there, to where because the pleura is inflamed, it's pushing back on the lungs, and so your lungs can't expand as much, so you can't breathe as much, right, as easily. And the results from somatic pain fibers that innervate the pleura, the parietal pleura. Characteristics are usually unilateral and abrupt onset, made worse by chest movements, rapid shallow breath, right? Because you can't take a deep breath. With pleural effusions, an abnormal collection of fluid in the pleural cavity. So this is where you just have fluid in that cavity where there's supposed to be nothing, right? And so because the fluid's it's just like the inflammation's pushing back on the lungs. And you have excessive fluid in that area, and it's not being removed by the lymphatics that can remove that. And there are a whole bunch of different types. If y'all want to, y'all can debold these. You don't have to learn these. That's just memorization. But there's decreases in lung expansion. So, right. Big picture, what I want y'all to get is that these, when your lungs can't expand, you can't get the same amount of oxygen, right? And pleuritis and pleural effusion, those are just two different ways that your lungs can't expand. Pleuritis is because of inflammation of the pleura, while pleural effusion is just a collection of fluid in the pleura. And there's also pneumothorax, the presence of air in the pleura, and this is the presence of air in the pleural cavity, right? Results in partial complete collapse of the affected lung, spontaneous air filled. So if you have an opening of the thorax, it can cause this air to come out, and you obviously can't expand because you don't have the pressure there. Air enters through the chest. So traumatic pneumothorax is where air enters through the chest cavities. You don't have to learn this one. This isn't going to be on the test. We also have interstitial lung disease, where the pathology is inflammation and fibrotic changes in the interstitium or the intraalveolar septum of the lung.
So atelectasis, whatever, and pleural effusion are decoded.
No. Keep pleural diffusion. You can just debold the types of pleural effusion, but just know like that these top 4 bullets.
Oh.
Yeah. Atelectasis. Yeah, you don't need to know that one. So with where was I at? Intraalveolar septum of the lung. So there's different causes. There's occupational, environmental, inhalants, drugs, and therapeutic agents, granulomatous disorders, and immunological disorders. Different clinical manifestations. Clubbing of the fingers and toes. Again, we saw that. Small but frequent breaths, non-productive cough, hypoxemia, cyanosis, hypercapnia, and respiratory acidosis. We've talked about this pretty extensively already, where we have pulmonary blood flow. So now we're looking at the actual blood flow through the lungs. And we talked about how with the peripheral artery diseases, we talked about how either anything that clogs that blood flow is going to be a problem, right? So whether it's a pulmonary embolism where you have a thrombus come out, things like a blood clot that's in your blood floating around and then coming in and lodging itself in essential arteries or veins, or is mostly going to be arteries, clogging itself into essential arteries of leading to the lung. These pulmonary embolisms can then block that blood flow to the lungs, and so you're blocking proper functioning of ventilation or getting gas into the blood flow. And then similarly speaking, pulmonary hypertension, where you have a hardening of those arteries and a buildup of fat deposits, and that whole development we talked about where you have blood clots determined. This happens a lot around the lungs because there's a lot of like branching of stuff around the lungs to oxygenate your blood properly. And a lot of these, we talked about how there's like swirling of the blood around the splits of where arteries are. And so because there's so many splits around the lungs, you have a lot of pulmonary hypertension that develops and a lot of plaque formation there. So yeah, your mean arterial pressure is less than 25 millimeters of mercury at rest, measured during right heart catheterization. And there's primary and secondary, but we don't have to go over that. So there's also cor pulmonale, right heart failure secondary to primary lung disease or pulmonary hypertension. Right, so this is where you have you have a problem with your lungs, and because of that, you're not getting good oxygenation back to the right side of your heart, and so your right heart isn't functioning properly from that. And it can happen, and the lung problem can either be a lung issue or a pulmonary hypertension issue. Clinical manifestations of the primary lung disorders: hypoxemia, hypercapnia. There's clinical manifestations of right heart failure. You have increased, this makes sense, right? Increased workload on the right heart because your heart's trying to compensate, and that leads to right ventricle hypertrophy because your muscle's working harder, so it needs to compensate and get bigger. And then eventual failure of the right ventricle because there's so much pressure being put on that ventricle. Not pressure, like there's a higher work demand of the right ventricle. Especially if there's this pulmonary hypertension because you're trying to force more blood through the area. So you have increased blood pressure in that area leading to the lungs. So the heart needs to pump harder to have flux through that area. Good, yeah. So we also have ARDS, which was talked about a lot during COVID, because COVID causes acute respiratory distress syndrome. It's life-threatening reaction to injuries, trauma, burns, aspiration, massive blood transfusion, alcohol abuse, or acute infection, and that's where COVID comes in. You have infectious pneumonia or sepsis. It's a severe lung syndrome. It's not a primary disease. So the reason why it's not a primary disease is because it's not the. So we'll use COVID as a good example here. It's not the virus killing of the alveolar cells that causes the damage or that causes the disease. What happens is the virus is there. Your immune system is responding to that virus. It then kills the cells contained within the virus, as well as a whole bunch of non-infected cells. All of those cells can have fluid in them, and so when you have a massive destruction of cells, it releases all the cytoplasmic contents into the lungs, filling up your airspace, and because the airspace is so full with fluid, obviously gas can't get in. And so you can't breathe very well. You have this acute respiratory distress syndrome. You can't breathe very well because all the fluids in your lungs. But all the damage is caused by the immune system. It's not caused by the virus. So it's a secondary, where does it say it? It's not a primary disease, right? Mm-hmm. So the goal would be then to get the fluid out of the lungs, and you can try mechanical ventilation. A less severe form is called acute lung injury. This term is no longer really used, though. Untreated with treatment. All right, jump the gun on this one. The clinical syndrome characterized by severe dyspnea of rapid onset oxemia and bilateral pulmonary infiltrates. Pathology, diffuse epithelial cell injury. Yeah, so this epithelial cell injury is what we're referring to, the cells that are destroyed by the immune system. Increased permeability of the alveolar capillary membrane. Increased permeability is just referring to the fact that these cells are dead and releasing all of its contents. There's a lot of presence of neutrophils. All the entire immune reactions there. And we just remember neutrophils are the first to be recruited, and so they're going to cause a lot of the damage there. But they release the pro-inflammatory mediators. If you remember, neutrophils are a granulocyte, so they release a lot of pro-inflammatory cytokines that cause all this damage and inflammation. Respiratory failure is a condition in which the respiratory system fails in one or both of its gas exchange functions, oxygenations, mix, venous blood, and elimination of carbon dioxide. So there are two main different types: this hypercapnic respiratory failure and hypoxemic respiratory failure. So hypercapnic is referring to the depression of the respiratory center, disease of respiratory nerves or muscles, and thoracic cage disorders. While hyperoxemic is the failure of the gas exchange itself, mismatching of ventilation and perfusion and impaired diffusion. Interstitial lung disease, ARDS, pulmonary edema, and pneumonia. So that's it for this one. Let me get this